Okay, so imaging of multiple pregnancy. Just to preface this, I'm going to be talking primarily about twins, with the understanding that a lot of the principles of twin pregnancies will also apply to higher order multiples, but within our time frame, the further intricacies of higher order multiple pregnancies are really outside our scope. So essentially, I'm misleading you with my very first slide. Okay, I'll be not talking about triplets at all, or kittens for that matter. Okay, so this is our structure for multiple pregnancy, and really this will cover most of the topics that you will encounter in a problem-solving scenario when dealing with a multiple pregnancy. We'll talk about establishing chorionicity and amnionicity. We'll talk about detection of fetal anomalies in a multiple pregnancy, growth restriction, and a group of conditions which I'm sort of lumping as complications of placental sharing. So establishing chorionicity and amnionicity in a multiple pregnancy is not just semantics, okay? This is your first point of risk stratification. This is what determines what conditions we actually look for in this pregnancy, and it determines the schedule of follow-up scans, particularly in the late second and third trimester. Okay, now that said, it's not difficult all the time. A lot of the time it's quite straightforward. So this is a case, for example, where we're seeing a single gestational sac in the uterus. Here is one embryonic pole that's clearly sitting in its own amnion, and there's his yolk sac. And then further along in this scan, we've got another embryo, also obviously in an amniotic sac with its own yolk sac sitting next to it. So this is a fairly beautifully seen monochorionic diamniotic pregnancy. This, on the other hand, we've got two babies that are very closely together, located in a single amniotic sac, which hopefully are projecting fairly well there, the amnion. There's only one yolk sac associated with this. So really, this is straightforward monochorionic monoamniotic pregnancy, and the only issue in this case was trying to demonstrate that these babies were not actually conjoined twins, which they weren't. Here we've got clearly two chorionic sacs right next to each other. So this is one sac with one baby. This is another sac with another baby. Just looking here briefly, these babies actually incidentally looking quite different. So this one's looking a lot more echogenic. This one here, if we screen through, is somewhat edematous. It's smaller and there's no fetal heart rate. So in this case, it actually happens to be that this is early fetal demise in a dichorionic diamniotic pregnancy. The other baby looking very normal with cute little limb buds and a normal heart rate. Now we're coming to a different appearance which we're seeing in later first trimester. So all of those cases where the appearance is in early first trimester. Now we're dealing this later first trimester around about the 11 to 14 week mark, where we introduced the concept of an intertwin membrane. And an intertwin membrane can be one of two things. If it's a monochorionic pregnancy, such as in the case on the left, it's actually going to be the layers of two amnions fused together. And to be able to establish that that's what it is, we really need to look at its margins and look for its connection to its sort of the border, where it's not going to be thickened at any point and it's going to hit this T intersection. So that's the T sign of a monochorionic diamniotic pregnancy. Whereas in the case on the right, the appearance in the mid portion is fairly similar between the two cases, but in fact this is the thinned appearance of the two chorions as they get larger. And we look for that thickening at the margin, forming the twin peak sign or the delta sign of a dichorionic pregnancy. And this is considered to be the ideal time to be assessing chorionicity in a pregnancy, between around about 11 to 14 weeks, before the fetal parts get bigger and it becomes harder to look at the membrane. So these were all the straightforward textbook cases. When might we get in trouble with this, or when might we encounter difficulty, and how can we problem solve? So I'm going to talk about two pitfalls. Pitfall number one. You've got a single chorionic sac, you've got two babies, and you can't see a membrane. And you're wondering, is this actually a monochorionic monoamniotic pregnancy, bearing in mind that they are only about 5% of monochorionic pregnancies, or is it a diamniotic pregnancy and I'm just not seeing that amnion? And that may be because of patient factors or machine factors or just your own bad luck. Pitfall number 2 is generally in later pregnancy when you've got that thinned membrane and you're looking to try and establish, is it a T sign, is it a delta sign? You just can't see it. Is it a dichorionic pregnancy or is it monochorionic pregnancy? So let's have a look at other things we might look at to help ourselves along with this. So first, couple of points addressing pitfall number 1. Definitely monochorionic, is it diamniotic or monoamniotic? So you can look for a number of yolk sacs. And for a long time, this was considered to be a very reliable feature in monochorionic pregnancies. If you've got 2 yolk sacs, that equals 2 amnions. If you've got 1 yolk sac, that equals 1 amnion. And it is true in the majority of cases, but there have been a series of case reports in literature demonstrating it to be incorrect both ways. So it is somewhat helpful, but you cannot rely on it as a primary sign. On the other hand, if you see entanglement of cords, it is absolutely diagnostic of a monoamniotic pregnancy, right? They cannot entangle unless the 2 babies are sitting in the same cavity. Addressing our second point of potential confusion, monochorionic versus dichorionic pregnancies. Again, you can look at number of placental masses and you can say if there are 2 placentas, that most likely this is a dichorionic pregnancy, right? But again, there's some provisos where if you've got 2 placentas that are growing very close together, you can actually falsely have the appearance of there being a single placenta. And conversely, a placenta with a succenturiate lobe could potentially mimic the presence of 2 placentas, okay? On the other hand, if you've got discordant fetal gender, that is clearly a diagnostic of a dichorionic pregnancy, and if the gender is concordant, that it is no use to you whatsoever. So the first one of these 2 signs is somewhat helpful for you, but not diagnostic, whereas this second set of signs is diagnostic if present and not helpful if not present. So just to illustrate a couple of points, this is the only triplet pregnancy that I'm actually showing you. We've got 2 gestational sacs, we've got 1 fetus on here, we've got 2 fetuses there. And in no images can we see the amnion, okay? And so this was actually in real life called a monochorionic monoamniotic pregnancy initially. But with a little bit of our foresight here, we actually see that we've got 2 yolk sacs. And we say, well, it still could be a monoamniotic pregnancy. But given this appearance, it's actually most likely not. So what are we going to do? We're going to scan them again. So you have to raise the point that you haven't got complete diagnostic confidence and you have to scan them again. This is just to show you an image of entangled cords in a monoamniotic pregnancy. So this is a nice appearance of 1 cord coming from here, 1 from here, and they entangle in the middle. So problem solving. If you're running into problems and you're not sure, you have to, 1, be clear about the fact that you're not sure. You have the option of rescanning at 11 to 14 weeks, unless you've gone too far, service later. You may ask for an opinion from your esteemed colleagues and get a tertiary review. Don't ask Frank about it per se. And if all else fails, you manage this as the higher risk of the pregnancies. So moving away from the chorionicity and moving on to anomaly screening in multiple pregnancy. So the principles of screening are the same for twins as they are for singletons, right? So you can still offer combined serum screening in the first trimester, and the accuracy of it isn't as good as it is in singletons, but it's still pretty good, okay? You can still offer NIPT, and there's been a recent meta-analysis in the White Journal of Obstetrics and Gynecology, so the UOG journal, demonstrating that NIPT is as accurate for diagnosis for screening of trisomy 21 in twins as it is in singletons. And of course, you still screen for structural anomalies, which is what we focus on. And in fact, structural anomalies are more common in twins than they are in singletons. Now, in a dichorionic scenario, the risk per baby is essentially the same, but you might argue that because you've got two babies, the pregnancy may have a slightly larger risk. But interestingly, monochorionic twins are in the order of 2 to 3 times more likely to have an anomaly, and that applies to all body systems. So that's cardiac, that's neurological, genitourinary, and so on, except not chromosomal. So they're not more likely to have trisomy 21, but they're more likely to have an abnormality. And what's somewhat counterintuitive is that the majority of these abnormalities are actually discordant. So you would think that two babies with the same genetic makeup would be likely to have the same abnormality, but a lot of the time one baby is normal and one isn't. And there are several theories about that, which means that nobody actually knows. But an interesting approach is that you can consider the process of twinning as being something of an anomaly in itself. And so there's one theory that perhaps the process of twinning is actually separating, in some cases, an abnormal twin mass from the healthy baby. So a few examples. This is a monochorionic monoamniotic pregnancy, and we see that because we've got an image of entangled cords here. Twin 2 on the right is entirely normal, and twin 1 is lacking the normal cranial structures. So this is a twin pregnancy discordant for anencephaly. Here is a monochorionic diamniotic pregnancy. Twin 1 here is entirely normal. Twin 2, what are we looking at here? We've got a small and abnormal shaped cerebellum. So we've got our banana cerebellum. So you know what comes next: the lemon head, ventriculomegaly, and the myelomeningocele. Okay. This is a slightly unusual case. We've got a dichorionic diamniotic twin pair. Both twins have got complete lack of amniotic fluid. There are no kidneys in the renal fossa on either side, and we can see the pictures of the aorta with no renal arteries on each side. So clearly an unusual scenario with both twins having the same anomaly. Clearly there's a genetic predisposition with high penetrance genetics, and these guys actually had consanguineous parents who were first cousins. Moving on to twin growth and survival. So we know that twins consistently have slower growth than singletons. And this starts fairly early. This starts as early as about 8 weeks gestation. And our challenge as clinicians is to establish at which point this represents adaptation, and in which case this is abnormal pathologic growth restriction. And so what are we going to do to these babies? Well, we're going to do what their parents are going to be doing to them for the rest of their lives. And I say this with an authority of being a twin parent. We're going to compare them. We're going to compare them to each other as well as to all the other babies on a chart. Okay. So we look for discordance in twin pregnancies from very early on. And early on in the first trimester, CRL discordance of more than 20%, and in some papers it's even more than 10%, is associated with very poor outcomes for the smaller baby. Okay. Later in first trimester, this also applies, but the sensitivity and specificity isn't as good. But certainly you should be reporting twin discordance in early pregnancy, particularly early on. In later pregnancy, we introduced the concept of selective intrauterine growth restriction. Now, again, this specific numerical definitions vary somewhat in the literature, but it's fair to say if you've got a one baby that's small, so EFW less than 10th centile, and there is a growth and there is discordance in size between the babies, assuming that we have already excluded any fetal anomalies, right? So structural abnormalities that may have resulted in the baby being small, and assuming that there is no twin-twin transfusion syndrome, and we'll talk about that a little bit more later on. But in this scenario, we talk about selective intrauterine growth restriction. Okay. So this is an example of a growth chart. Two babies, so you can see the baby that's marked by the circle is growing very beautifully alongside the 50th centile, whereas the second baby had started off smaller fairly early on, but clearly after 30 weeks it's dropped off to clearly a growth restricted state. what do you need to tell the clinicians in these scenarios? So obviously you tell them the fetal weight, you establish that there's no twin-twin transfusion, and you do the fetal Dopplers, and in particular importance for you is the umbilical artery Doppler, because it actually stratifies risk and subtypes the selective IUGR, okay? So type 1 selective IUGR is when you've still got a positive end-diastolic flow in the umbilical artery, and it's associated with a generally fairly good prognosis. Type 2 is when you've either got an absent or reversed end-diastolic flow, as we have here, reverse flow, in the umbilical artery. That's associated with predictably poor prognosis. And there's another subtype called the type 3, where there is intermittent absent or reversed end-diastolic flow, and prognosis is somewhere between type 1 and type 2. So it's not as bad as type 1, but certainly it's worse than type 1, and you can have unexpected fetal death in utero. Just mentioning quickly the scenario of co-twin demise. Before 14 weeks, you have the situation of the vanishing twin. So that's sort of what we saw with the dichorionic dimeotic pregnancy earlier on when we were talking about chorionicity. This essentially results in no developmental detriment to the surviving twin. After 14 weeks, however, the surviving twin is at risk of death in utero and neurological injuries, so it needs to be monitored closely, and this is an indication for fetal MRI. Okay. So this is sort of the group of conditions that which I've lumped in together as complications of placental sharing. Now, intrauterine growth restriction was a complication of placental sharing to an extent as well. What's different about these three conditions is that they all have a single placenta, so they all must be monochorionic pregnancies, and they have abnormal interplacental anastomoses. So twin-to-twin transfusion syndrome, of course, is the most common one, most well known. Its hallmark and its definition is oligohydramnios in one sac and polyhydramnios in the other. Okay. The etiology is the presence of vascular anastomosis within the placenta. Now, there's always, or virtually always, some degree of interplacental anastomosis in a monochorionic pregnancy, right? What happens here is that the anastomoses are numerous enough that there is a significant flow from the donor twin to the recipient twin. What happens with the donor twin is you've got activation of the renin-angiotensin system, so it's actually an endocrinological process which results in oliguria and oligohydramnios. And conversely, of course, in the recipient twin, there is hypovolemia, which results in polyuria and polyhydramnios. I just want to clarify with the diagram on the other side, there's often a point of confusion where perhaps in certain reports, the presence of selective fetal growth restriction is referred to, or its absence is referred to as being indicative of the presence or absence of twin-twin transfusion syndrome. I just want to clarify, the presence of fetal growth restriction in the absence of oligohydramnios, polyhydramnios is not an early stage of TTS, right? It's certainly pathologic, but it's a separate condition, okay? Twin-twin transfusion syndrome may exist with or without fetal growth restriction. You will probably be familiar with the Quintero staging, which is not only helpful for actually determining the planning of management in a twin-twin transfusion, but is actually quite helpful to know in the exams because it tells you exactly what to look for, right? So you look for, beyond establishing that you've got oligohydramnios, polyhydramnios, you look for, to see if you can see the twin, the smaller twin, the oligohydramnios twin bladder. So if bladder is not visible at stage 2, you look for abnormal Dopplers typically in the oligohydramnios twin. You look for hydrops typically in the recipient twin, and of course for fetal demise. So showing you a case really quickly, this is obviously a twin pair. You've got this baby which is surrounded by a lot of amniotic fluid. This one is the recipient, so what's known as the stuck twin, because the amnion sticks it to the side of the uterine wall. And in this case, the bladder was present, everything else was normal, so this was stage 1 twin-twin transfusion syndrome. I won't spend too much time on that. This is just another case, same sort of condition on MRI. So you can see this baby's floating freely in a large amount of amniotic fluid. This one's really stuck down to the wall. You can see just the amnion sticking it down right there. Now this pregnancy was treated with laser photocoagulation, and this is a picture just days later showing equal fluid between the two twins. So a good result in this case. Twin anemia polycythemia sequence is in some ways a related condition. You also have vascular anastomosis that result in flow from a donor twin to a recipient twin. But the flow is to a lesser extent, so it's sort of a slower transfusion that doesn't activate that endocrinological process and doesn't result in oligohydramnios and polyhydramnios. What happens, however, is that the donor twin becomes anemic and the recipient twin polycythemic. And this may occur spontaneously or following laser for twin-twin transfusion syndrome. Now, if these babies were born, you would see clearly that one of them is pale and the other one is very pink, but of course we can't see that with ultrasound, so I've got no pictures to show you other than showing you the diagnostic criteria based on the MCA PSV. And the first set is the well-established criteria that most people will be using, and the second one is actually from a recent sort of this year's publication, so it's probably going to be the newer approach, but it's anyway, that's the diagnostic approach to TAPS. A different situation altogether, but also with an abnormal vascular anastomosis. The prerequisite for a twin reversed arterial perfusion is the presence of early fetal demise in one monochorionic twin, plus the presence of artery-to-artery anastomoses between the two twins. So what happens is that the well-growing twin, the arteries that flow away from this baby will connect to the arteries of the acardiac twin, so one that doesn't have a functional heart. There will be retrograde flow through these arteries towards this baby, so of deoxygenated blood. So this twin, the well twin, is pumping extremely hard to support a non-viable twin. And then the heavily deoxygenated blood will then flow back towards this baby, causing further cardiovascular compromise. So this is a case of monochorionic babies. This is a well twin. This you can see is extremely hydropic twin. This is the normal baby, normal baby, normal baby, normal baby, abnormal baby. So head, hydropic, abnormal mass without really well-defined fetal parts. Vascular anastomosis, superficial vascular anastomosis through the placentae. And this is the key image, and it's kind of, it's tricky, but if you can see this is very helpful. This is actually the cord going to the abnormal twin, and you can see that flows in this direction. So this is abnormal direction for flow in an umbilical artery, right? It's reversed. And just one final word of caution. Beware the trap, okay? Beware the situation where you've got a single fetal demise early in pregnancy and the baby's not getting smaller, so it's not in the process of vanishing, so to speak. It actually stays the same or gets bigger, okay? You have to look really carefully for the vascular interconnections and pick this, because of course this presents a risk to the surviving twin.